Hello class. What I'd like to do now is just kind of provide you a summary of what you would have normally done in lab for tomorrow's session. And we're going to continue with our concept of comfort. And the first thing I wanted to talk about is if you had been in lab, we would have showed you this movie. And it was about a newborn boy who was getting circumcised. And the movie portrays the procedure, and obviously the healthcare provider or the physician is present, as well as the nurse. And the focus is not on the procedure, it's on the role of the nurse and what the nurse is doing. I had that YouTube video for you and I was going to show it to you, but unfortunately what happened is many times we as faculty who pick out some of these videos to demonstrate or teach about the concept, they're removed from YouTube. This video could be a little bit alarming for some people to watch. This child gets circumcised, so they did take it off YouTube due to violating community guidelines. But like I said, it wasn't about the circumcision, it was about the nurse and how she helped this newborn get through the procedure. And so what I wanted to talk about was the importance of the nurse and the way that she can help patients alleviate their pain. And it isn't necessarily through medication. That could be a part of it, but it isn't always the option that we turn to immediately to help our patients with their pain. And with a newborn or even a child, it's sometimes very difficult to assess whether or not the patient who is that young is in any distress, because they cannot verbalize to us exactly what the problem is. Is it pain? Is it hunger? Is it abdominal distress? Is it loneliness? Is it that the baby's cold? Is it that the baby has a soiled diaper? So these are all things that we really don't have the answers to, as we do many times with our adult population, or even a child who could verbalize, yeah, my tummy hurts, yeah, my arm hurts, these kinds of things. So what we do as nurses, we have to devise tools that can help us better identify if our children or babies or infants are in any kind of pain, and to also assess to what degree of pain these children are in. Now, as nurses, when we are with children or infants at a time where they may be having or displaying signs of distress, this video would have portrayed the nurse at the bedside of this baby as it was going through this procedure. And it would have been nice to visualize just how wonderful this nurse was for the baby. Obviously, they had to strap the baby down so the baby wouldn't move, but the nurse was also very present there at the side of the baby. She was soothing the baby, she was talking to the baby, she was touching the baby. You could hear her in this video very much, shushing the baby and kind of letting that baby know that her presence was there. She also provided padding to the board that the baby was on. She gave the baby a pacifier just to soothe that distress that the baby was in. She also put her hand on top of the baby, and after the procedure was done, she immediately picked up the baby and swaddled the baby and really provided that physical comfort to the baby. And that's very much what we can do with infants and even with some of the children. We watched that video last week on a child's experience in the hospital. And many times the experience was not so devastating to those children because mom and dad were there. They had some familiarity, within their environment when they were going through, either it was being a patient in the hospital or going through a really scary procedure. So I just wanted to press upon the fact that as nurses, we do provide comfort to our patient through pain, with their pain, to provide that comfort just sometimes with our presence and talking to them. And it not only helps relieve some of that physical pain, but also some of the emotional pain that people are also suffering from. And many times our role is at the bedside of the patient. I know from my experiences as a nurse, there were times that we were there for our patients because the physician decided to do a particular procedure at the bedside. So first of all, my role was to be sure that all the proper equipment was there, because there's nothing more frustrating than to start a procedure and everything isn't there that the physician needs to get the procedure done as quickly as possible. When there's a lot of chaos and the doctor's a little bit upset because things aren't there that he needs, it also increases the stress level of the patient, and you don't want that to happen, because sometimes with these procedures, the patients are very fearful of what's going to happen. They're worried that it's going to be painful, and they're also worried that they're going to find something seriously wrong with themselves. So it's really important that first of all we make sure that everything is in the room, and then we of course explain the procedure to a person that is able to understand it. Many times we can tell children, as this was displayed in the video we watched last week, about exactly what was going to happen. And I guess along with children, we also need to be honest with the adults. Yes, you may feel this. Yes, it may be a little bit painful, but this is what's going to happen to hopefully keep that pain level down. And again, we do assist our healthcare providers with these procedures, but our main goal is to help keep our patients comfortable, to be there for support, and to definitely reduce their anxiety, and to definitely make sure that they are experiencing as little pain as necessary. Many times I remember when some of my patients would be going through some of these tough times, I would definitely provide them maybe some slight sedation so they weren't so nervous about the procedure, the upcoming procedure that's about to happen. I would definitely let them know I'm going to be there with you, so if you need anything, let me know. We've already established that trust in our relationship, so they really appreciated the fact that I was going to be there with them, because they knew that I would be able to help them if any complications or there was anything that they needed during that particular procedure. So we do this for our children and for infants as well. Some procedures we may allow mom and dad to be in the room. Other procedures we prefer that they're not there. So if our parents are not there for these kids, we have to be that person that the child relies on to help get them through it and to ease some of their anxiety as well as some of their discomfort. And yet we're there for our physicians to make the procedure go through pretty quickly, and to just make sure that we provided them with all the necessary tools and equipment needed to get the procedure done as quickly as possible. In classes, we talk about pain. Please refer to your health assessment book, your D'Amico and Barbarito. It's on page 119 in table 9.3. It talks about lifespan considerations related to the pain experience. So as we look at that particular age group, this table is very nice because it depicts how that particular population perceive pain and what kind of behavior you would see, which could clue you in as the nurse that the patient is having pain. And then the next column is about what kind of nursing interventions would I provide for that particular situation. And as you can see, the first group is infants. They do perceive pain. They respond to pain with increased sensitivity. Older infants try to avoid pain. For example, they turn away and physically resist. So as a nurse, you might give an infant a glucose pacifier or use tactile stimulation, play music or tapes of a heartbeat so that it resembles what those babies were feeling in utero. So as you can see, this is all provided through the toddler and the preschool, the school-age child, the adolescents, the adult, and the older adult. So I think this is a really good table. I think I have this on a hard copy, and I'll download it into Canvas under week 2, along with the different types of pain scales. The pain scale that I have up here on the screen is a very common pain scale that you may give to a child, because obviously it may be difficult for them to rate that pain on a scale of 1 to 10. So these are faces which depict, whether or not something is really hurting the child a lot or just a little bit. And you can explain how this pain scale works, explain to the person that each face is for a person who feels happy because he has no pain or he isn't hurting, or sad because he has some or a lot of pain. Face 0 is very happy because he doesn't hurt at all, and face 1, is just a person or a child who's hurting a little bit. This is a very common pain scale that we use for persons aged 3 years and older. So this is what we would give a child, and it works very, very nice, and it really gives us that information that we so much need as to, if the child is having pain and to how serious that pain is. And again, point to each face using the words to describe the pain intensely, the intensity of the pain, and ask the child to choose the face that best describes own pain, and then you would record that appropriate number. And I know you're all familiar with this pain scale. This is the very common pain scale of 0 to 10, where there is no pain with 0 and the worst possible pain with 10. And you can see as we advance up that scale, the intensity of the pain is there. And remember too, as I said yesterday in the lecture video, that whatever a patient or a person says is their pain, that's what it is. And there's no disputing that. Whether or not the patient looks like he is in that much pain, it doesn't matter. That's what the patient tells you. And this is another scale that is about, looking at the developmental stage, the response to pain, what you may see happen with that particular age group, and what, again, are some of the nursing interventions. Very close to the one that's in your health assessment book. I'm not going to read each one of these, but I think it gives you a good idea of what happens when that particular age group is experiencing some kind of pain. Just like for the adolescent, may deny pain in the presence of peers, exhibits changes in sleep patterns or appetite, exhibits body control, may regress to earlier developmental stage in the presence of a trusted adult. And these are things that we might do for that particular age group. And one of them is to maintain privacy and encourage distractions such as music or TV to deal with their pain. So I just wanted to bring this to your attention as well. The 2 pain scales and this I will definitely put in your Canvas course, so you'll have that at a later date for reference. And this is just an example of how a baby may respond to pain, what kind of physical assessment you might make with that baby. And as you can see, a baby that's in pain will have bulged brows, brows lower, drawn together, eyes squeezed shut, furrowed nasolabial creases, taut tongue, open, angular, squarish lips and mouth, and of course that baby's going to have that quivering chin, and we see that very often when these infants begin to cry due to the fact that they're in pain. So I just wanted to kind of show you that that's another way that we can kind of learn about what is wrong with that child, especially if he starts to cry. This is kind of the way the child will present when he is in some type of pain. Class, here up on the screen I have two different types of neonatal infant pain scale that you may use with a child to determine their pain level. The first one is the neonatal infant pain scale. It's the NIPS, and as you can see, obviously with a child not able to verbalize, you would definitely give them points depending on how you would assess them physically. Facial expression, are they relaxed? No points. Contracted, 1 point. If they're crying, mumbling, or vigorously, and so forth and so on. Maximum score of 7 points considering pain if a score is reached of 4 or higher. The other one is the FLAC pain scale, and again it's very similar. You're looking at their face, their legs, the activity, if they're crying, and consolability. So I wanted to provide you with these two types of pain scales that you may use to kind of assess at what degree of pain an infant is having, or if they're having pain at all. So please be familiar with those. Now, as Nursing 100 students, what we do is linear concept maps, and you're going to be taught how to do these. And if we had had lab tomorrow, you would have been kind of instructed on how to do these concept maps. It's a good way to kind of get a focus of what is going on with the patient. And as you can see, this is a very simplistic type of concept map. As you advance more in the program, these will become much more complex, much more sophisticated. And in that first circle, what you're going to list is the subjective and objective data relevant to the problem you identified. And then that will take you to the next circle, which is the patient problem. Name the problem that nursing can help. Then the next circle is why this is happening. You might want to identify some causes for this problem and how you know it is a problem. And then now, because you've identified the problem, you are going to provide nursing interventions. And these are interventions that are based on evidence-based practice. We're not just throwing out things that we're going to do for the person or the patient just because we think that might help. These interventions are based on research that tells us these are things that we would do for that particular problem, and we have good outcomes from these interventions, and we would definitely document where that is stated so that we have the evidence to back up what we provide for the patient. And then the expected outcome, followed by what do you want the patient to turn out after these interventions are provided for the person. And we look at what we call SMART goals. And what that acronym SMART means is that our goals are specific for S, measurable for M, A is attainable, R is relevant, and T is time-based. Because we have to think about when we provide these interventions, we want to see those outcomes show up soon. We don't want to say, oh, a year from now we hope this happens. No, we would like to say within 2 days, this is what I would like to see the patient present. So that's what is very important when we talk about that acronym SMART in regards and reference to the goals that we hope to see happen with the patients when we provide these particular interventions. Now I am providing you an example of the linear concept map. Had you viewed that video, this is the information you would have obtained from it. In that first circle, we're providing you the subjective and objective data. The baby was crying, shaking extremities, the face was red in color, uncomfortable, patient positioning, okay? Patient problem was acute or cutaneous pain, And why is this happening? Obviously, it's a circumcision that's been ordered by the parents, because in order to perform this procedure, the parents would have had to sign a permit. What are some of the nursing interventions? And as you can see, we have documented and showed the evidence behind those interventions. Provided a glucose pacifier. Sucking on a sugary pacifier can ease pain during medical procedures. They use the pain assessment using the FLAC, Accurate and Timely Patient Assessment, is imperative for effective pain management, and that's provided in your Barbarita book. And what we would like to see is the FLAC score will remain 5 or less during procedure, and infant will use pacifier during the procedure. So that's kind of an example of how we would do concept maps, and we'll be doing those in lab, as well as you doing them not only in lab, but also in clinicals, and when time allows, we'll also do them in the classroom during lecture. So I wanted to go over this with you because this is something that you want to learn how to do now, and you'll get better and better at it. But it really does take you through a very good process of kind of pulling out the necessary information so you can understand what's going on with your patient, and then provide, evidence-based interventions to hopefully see good patient outcomes. This kind of takes the place of care plans, which students prior to that would use books and just kind of jot down any old intervention and not look at the patient as an individual and what is specific to that patient. So with the linear concept maps, it gives students an opportunity to really think about what's going on with their patient and to know how to pull out some of that data that they obtain either using our senses and as well as doing our patient's health interview, and always continually to update that so that we can provide very accurate information in each one of these circles. So I think that's most helpful when we talk about linear concept maps. So if you have any questions on that, let me know. But like I said, you're going to be doing a lot of these, and it's okay if you do have questions still. Ask your instructors, but we'll do some together, like I said, in the near future. And here on the screen is a pain assessment that if we were in lab, you would complete on your lab partner. And I think it's important, just please review what some of the questions are, because now we're looking at specifically pain and where is your pain and what words would you use to describe your pain. And as you can see, there's quite a few here that really give us a better idea of what kind of pain you're having. Is it occasional or continuous? What time of day is your pain the worst? And then to rate that pain. What makes your pain better? What makes your pain worse? So these are kind of great ideas in which we can ask our patient to get more of an idea what's happening. What treatments or medicines are you receiving for your pain? And what other associated side effects or symptoms are you having? Because sometimes with pain, these very much accompany a person when they are having that pain. For instance, patients who have MIs may experience nausea and vomiting. Do you have constipation? Do you have no appetite at all? Are you tired? Are you itching? Do you have nightmares? Do you sweat a lot? Is your cognitive abilities impaired by exhibiting difficulty in thinking, or is your pain keeping you up at night? And this is just to help understand if you've been having pain, has it interfered with things such as, sorry, I scrolled down too fast, general activities, your mood, normal work, sleep, enjoyments of life, concentration, and your relationships. And these are also to describe your preferences on managing pain symptoms. Do you do it by yourself? Do you have home remedies? Do you seek your healthcare provider? Do you have an alternative healer? Do you kind of reach out to your friends and family and say, this is the kind of pain I'm having? Will not treat the symptoms unless they are unbearable. Maybe sometimes you just don't even bother to seek medical attention until it's extremely, extremely devastating. Okay. All right. next we're going to kind of shift our gears from pain to sleep. We talked a little bit about this in the lecture, and we're continuing that conversation now in our lab. And first of all, I'm going to show you this little video on sleep, so bear with me.
It's Ellie and Helen with Julie Mama 3. Hey, Julie needs to keep recipes simple and delicious. Yes, challenge accepted. We've got cheese, bread, Hellmann's. Trust me, it's perfectly crispy grilled cheese. Whoa. Hey, it's Ellie and Hellmann's with Julie Mama 3. Hey, Julie needs to keep recipes simple and delicious. Yes, challenge accepted. We've got cheese, bread, Hellmann's. Trust me, it's perfectly crispy grilled cheese. Boom! She likes it. Her kids will love it.
Tired? We all know the feeling. Irritable, groggy, and exceptionally lazy. Chances are you didn't sleep enough last night, or the past few nights. But what exactly is enough sleep? And more importantly, can you ever catch up on it? While the very function of sleep is still debated by scientists, we do know that it's necessary to function efficiently and productively. After all, we spend 24 years of our lifetime sleeping, it'd better be important. Researchers have tested how much is required each night by assigning groups of people to 4, 6, and 8 hours of sleep over extended periods of time. After 14 days, those with 8 hours of sleep exhibited few attention lapses or cognitive issues. However, those with 6 or 4 hours of sleep showed a steady decline. In fact, after only 2 weeks, the 6-hour group showed a similar reaction time to a person with a blood alcohol concentration of 0.1%, which is considered legally drunk. The 4-hour sleepers suffered even more, occasionally falling asleep during their cognitive tests. In both groups, brain function decreased day by day almost linearly with no sign of leveling off. Scientists have dubbed this cumulative effect as sleep debt. So can we recover from it? After a night or two of little sleep, studies show that the body and brain can fully recover with a few nights of good sleep. However, with long-term sleep deprivation on the scale of weeks to months, the recovery of cognitive function is much slower, requiring many more nights of quality sleep. On the timescale of months to years, it's unknown whether brain function can be fully repaired or if it causes permanent damage. Paradoxically, with chronic sleep deprivation, your sleepiness or how tired you feel does eventually level off, meaning that you become less and less aware of your objective impairment over time. So, how long should you sleep? Most studies tend to show that 7 to 8 hours of sleep is the average ideal for humans. Apart from the cognitive issues, individuals who consistently sleep less than 7 hours a night have an increased risk of heart disease, obesity, and diabetes, not to mention a 12% higher risk of death. On the flip side, studies have shown that while sleeping more than 8 hours does not impair brain function, it also carries an increased risk of heart disease, obesity, and diabetes, and a 30% increased risk of mortality. So, too much sleep may also be a bad thing. But variation most certainly exists, and our genetics play a large role. In fact, individuals genuinely unaffected by only 6 hours of sleep were found to have a mutation of a specific gene. When scientists genetically engineered mice to express this gene, they were able to stay awake for an extra 1.2 hours than normal mice. It turns out these short sleepers have more biologically intense sleep sessions than the average person. Ultimately, while it's important to know the ideal average of 7 to 8 hours exists, let your body and brain help you figure out its own needs. After all,
I really like that video I just showed you, because think about what it tells you about adequate sleep and your needs to be a healthy adult and student. I really wasn't even aware that when you're deprived of sleep, how it could be very comparable to someone who's legally drunk. So I guess that really is a very powerful statement that shows us that, without proper sleep and rest, we could be at risk for causing errors and serious harm to our patients. Okay, so that's why, I think it's important to know that when you're having a very busy day, and part of that day is being responsible for taking care of patients, it's important that the night before that you get a good night's sleep. And and even after you graduate, when you get assigned to a particular unit and you've got your assignment, it's important, especially now with nurses having to work 12-hour shifts and maybe even the night shift, that you can see by just from the information from that video, it really shows that why nurses start to really lose their energy and their cognitive thinking, and it's hard for them to make decisions. And you can see now why there's a lot of errors being made in the hospital or the healthcare environment. And think about what factors influence your ability to sleep. Maybe you're going through a tough time. Maybe you've got a personal issue. Maybe it's the medications that you take. Maybe the environment in which you sleep in is really holding you back and providing a lot of barriers that prevent you from getting a good night's sleep. Some of you may have young kids that try to crawl in your bed at night. Maybe you've got pets. Maybe your partner works late night hours and comes home and wakes you up. Maybe there's a lot of noises in your neighborhood or in your environment. And so think about what you can do to identify your expectations for a good sleep. Make sure, as I talked about in the lecture, some of those really important tips on sleep hygiene. Okay, your book in your Pearson Concept books on page 54 to page 55 really does talk again about sleep hygiene, offering some great tips on how to get a good night's sleep. And think about it. Fatigue is often the result of inadequate sleep. Nurses should promote and teach good sleep hygiene to all our patients with fatigue, sleep rest disorders, and acute and chronic illnesses that could cause fatigue. And some of the ways in which they provide good sleep hygiene includes, just like I went over, I'm not going to read these to you, but please review those 2 pages because, again, it reinforces the information that I gave you yesterday. Okay? Also, kind of think about how do alterations in sleep affect comfort in hospitalized patients. And that's a great question. Because we think as nurses we have this to do and that to do for our patients, but we don't realize that in order for us to get our work done, we may be interfering with our patients getting enough rest, and we have to think about that. We've got to organize what we do for our patients so they have some blocks of time in which they can maybe rest, take a nap, or refresh themselves, so it really does help promote healing and restoration of health. Think about some of the complications that are associated with sleep for patients that are in long-term facilities. And this would definitely apply to where you're at for your clinical experiences. Older adults in long-term care facilities are very much at an increased risk for developing sleep disorders. Similarly to community-dwelling older adults, patients in long-term care facilities have precipitating factors such as pain, gastroesophageal reflux, nocturia, dyspnea, and dementia, and they are often taking multiple medications that do interfere with their sleep. So you need to keep that in mind. In contrast to community-dwelling adults, individuals in long-term care facilities must also deal with the environmental factors that interfere with sleep, such as limited interaction with the community, reduced bright light exposure, physical inactivity, and nighttime nose and sleep disruptions. And I think hospitals and acute care settings also face a lot of those same problems with why they're not getting enough sleep. So just things to keep in mind, and as you say hi and interview your patients each week as you're assigned to a particular client, ask them about their sleep. Did you sleep good last night? And if you're not having a good night's sleep, what's going on that you're not? Sometimes it's just very simple things that you could help eradicate so these patients really continue to get a good night's sleep. As you see up here on the screen, another assessment we would have done with your lab partner called the assessment of comfort. Now we're looking at their sleep patterns, and again, looking in quite a lot of depth to see what kind of sleep people are getting every night. What kind of sleep do you think you have? How do you rate your sleep? And what do you think your sleep problem is? Make sure they understand these terms, what insomnia is. How long does it take somebody to fall asleep when they go to bed? They turn off the lights, no distractions. Do they fall asleep in 5 or 10 minutes? If I can't fall asleep in the first 15 minutes, I get up because I know I'm not going to fall asleep. and so forth and so on. I'm not going to read this whole assessment of questions to you, but I think some of them are very, very relevant. Sometimes these questions about sleep can lead the nurse and the healthcare provider in kind of pinpointing some other serious health problems that your patients may have. Indicate which, if any, symptoms you've been having at least weekly during the past month. Wake up with a dry mouth, you feeling anxious, difficulty concentrating, memory, morning headaches, feeling depressed, problems controlling your blood pressure, or disturbing dreams or nightmares. Sometimes our patients with diabetes will have those kinds of nightmares, okay, if their blood sugars aren't under control. And so you might want to kind of focus on these people that you know are diabetics, because a lot of these symptoms may be related to the fact that their blood sugars are not very well controlled. And these continue on the next page. Indicate which, if any, of the items listed below wake you up or keep you from sleeping. You need water, trouble breathing, racing thoughts, you can't turn off your mind, anxiety, and so forth and so on. Also, I always look and I say how important it is to know what medications your patients are on, because some of these problems that we're talking about are due to the fact that these are side effects of the meds that your patients are on. And if they haven't said anything to their doctors, doctors don't know that they're having these problems, so they keep them on the same medicines. But maybe you as the nurse, they have a little bit more of a better relationship, and they're going to tell you, yeah, I do have those problems, and I never thought anything of it until you asked me. So, yeah, I noticed that started happening when I started on this particular medication. Any allergies, and let them tell you if they're taking more than just prescribed medication. Sometimes they may have these issues with some of the herbal supplements or over-the-counter drugs. So it isn't only limited to medications that are being prescribed by their healthcare provider. So a real good way to assess these patients in regards to their sleep patterns or sleep habits. So this pretty much concludes what we would have done in lab this week on Monday had we had class. Please make sure you go over the readings or maybe review the video again. Like I said, sometimes the questions for the test are taken from any component of the course. So if you have any questions about this whatsoever, please let me know or let your lab instructor know on Wednesday. So I hope you're having a great weekend and enjoy your holiday. Take care.